Hi, my name is Johanna Fajardo. I'm a nurse practitioner in the Advanced Heart Failure and Transplant Program at Duke University Hospital in Durham. And I've been taking care of amyloidosis patients for over 10 years.
My name is Louis Koritsky. I'm a family medicine physician. Harkening back to what Dr. Fajardo said, I've probably been taking care of amyloidosis patients for more than 10 years also. I just didn't know it until this year. So I'm glad to have had the wake up call and be able to share such knowledge with our colleagues.
Yeah, hi, my name is Matt Moore. I'm a professor of medicine at Columbia University, where I direct the cardiac amyloid program.
Our learning objectives today include recognition of clinical characteristics of amyloidosis, identify when and how to refer patients to centers of excellence, and how to best prepare these patients to expedite their workup.
Hi, my name is Tim, and I have AL-type amyloidosis. Before the symptoms set in, which was very gradual, by the way, but I was living a normal life. I was working my job. My kids, my kids were getting out of college. I had one still in college, and we were living life, doing a vacation each year, and I had good health, and I've never really had any health problems, and I just assumed I would always be healthy. And but that was up until the symptoms slowly started to set in. I would say so. In 2018, or early in the year, I noticed that I did not feel good, and that's not much to tell your primary care physician. I don't feel good, but I wasn't feeling good, and I was struggling with energy level. And by the summer, I really didn't feel good at times, and I thought maybe we tried going on a gluten fast, uh, and and that really didn't seem to make a difference. But I tried that. Other symptoms by the summer of 2018 set in. My During the night, my wife would tell me that my legs would kick, and I would have leg pains during the day. I had carpal tunnel syndrome, and I I increasingly did not feel good, and my primary care physician was concerned. He he thought the restless leg syndrome medication didn't help, and he was throwing out some disease states that were worrisome. And the thing is, though, I it didn't seem that I could give him something concrete to work with. But that I guess that changed in by September. I was getting a life insurance upgrade, and they sent a nurse over to take my blood and urine, and then they reported back that there were very high levels of protein in my urine. And it was definitely an anomaly. And I went to my primary care physician, and he had me do a 24-hour urine test. That came back with very high levels. I believe we did another one. And then he introduced me to a nephrologist, a kidney doctor. And during this time, the symptoms really started to increase at a fast rate. I was feeling terrible. I was having a hard time sitting up sometimes. I later learned there was a name for it, orthostatic hypotension. And But I was having these symptoms. I was having a hard time standing up and even sitting up sometimes, and I had to lay down a lot. And and by the time I met with a nephrologist, my ankles started to swell. And so I was having very concrete symptoms at this time. I knew I had something serious. I knew something very serious was wrong. I would naturally I would search the internet, but it was a pretty broad spectrum, anything from kidney cancer. I mean, it was something serious. I knew there was something seriously wrong, and uh, and and so from the nephrologist, I got a kidney biopsy. They found amyloid in the kidney. This got me to an oncologist who did a bone marrow biopsy, and he confirmed the diagnosis of amyloidosis. And this was late October. By the time I formally got the AL type amyloidosis, and that was it was strange because I found out that I did have a diagnosis, and my physicians knew what was wrong, and in a way that was a relief, but at the same time it was bad news, very bad news, with that diagnosis of AL amyloidosis, the oncologist that made the diagnosis, he forwarded me to Dr. Goldstein at Siteman, and we met with him. I remember that very much. I was in a funk, but I remember that first meeting with Dr. Goldstein. I couldn't sit up. And so he managed my care from that point forward. And he told me, don't go out on the internet because we think it's early. And but that night when I was out on the internet, it's the one time I did not listen to Dr. Goldstein. I didn't follow his advice. I went out and searched the internet, and there was a lot of bad news. But later he would diagnose me as stage 2, which was earlier than a lot of patients that come to see him, and that made all the difference in the world with my story. I was stage 2. I started my treatment early, and I honestly believe that things were going downhill so fast that if my diagnosis was delayed by weeks or months, my story would be very different than it is.
Well, I just wanted to say that it is an amazing story, many that we've heard as clinicians. I think one of the things that we have to highlight is that everybody knew that there was something wrong. We just couldn't pinpoint it, right? The patient kept going to the physician with certain complaints, and the primary care provider was doing his or her best to send for referrals, to send for testing that was appropriate according to the large array of non-specific symptoms that the patient had. Unfortunately, as we know, with 20 minutes in a visit, primary care providers are often challenged in trying to figure out what's going on with the patient, where they have tons of differential diagnosis, and amyloidosis is certainly not at the top. So I think we have to recognize that even though what I admire of the primary care provider is that he or she never gave up. She continued to pursue the diagnosis with any new symptoms. They will do more workup, including the urine and the 24-hour urine, and then pursue to make the referral as soon as possible, which allowed the patient to have not as an earlier diagnosis that would have been if the patient would have been just seated stagnating with all the symptoms without any workup. That's one of the challenges with amyloidosis. I think that patients often have a long trajectory prior to getting a real diagnosis because of all this large array of non-specific symptoms that are being treated by several providers sometimes. And as we are just being focused to treat the symptoms and nobody's putting it all together, it causes the delays in the diagnosis. What are your thoughts?
Well, Joanna, I agree with you completely, and I thank you for your generosity because the diagnosis was not at all obvious from the beginning. And I think one of the things we want to share with our colleagues today is it takes a village to put this together. And what we're trying to share in addition are some markers of how to identify a disease that doesn't necessarily present straightforwardly. For instance, when people have celiac disease, everybody recognizes if you have abdominal pain or diarrhea, well, that could be celiac. But sometimes celiac disease presents as osteoporosis and iron deficiency and growth perturbation. And unless you're used to looking for the side stream clues to pull that diagnosis together, you may not do so. So I think the same thing needs to happen in this type of scenario where you're saying, all right, we know there's something wrong. This patient is an otherwise healthy young person and he's producing symptoms here. It's okay for anybody to get carpal tunnel syndrome. Anybody can have episodes of orthostatic hypotension. Anybody can have modest proteinuria after fever or strenuous exercise. But when you take a healthy young man like this and start to stack these things together, you have to think about it would be unusual for a young man like this to get three separate disorders that would present each with its own independent findings. What would link these signs and symptoms together? And that's how we end up coming up with the appropriate composite. Not so easy to do, but necessary for us to start thinking about if we're going to identify amyloidosis.
Yeah, I would echo all the sentiments and just emphasize the symptoms are protean. It's hard to put it together. Amyloid's rare, but you can never make a diagnosis unless you put it on your differential. And so what we encourage people to do is always think, could this be amyloid? And if you do that, I think you'll be well ahead of the game, especially in diseases that are confusing. I also think that amyloid is somewhat unique in its serologic evaluation, at least AL amyloid. We have a fantastic blood test. It's the only blood test I know in medicine, and that is the uh, diagnostic of the disease. That's the light chain. It's prognostic of the disease. It tells you about one of the key aspects of staging, and it's the target for therapy. There's no other biomarker in medicine that does all three things in a single blood test. So I jokingly tell people, maybe not so jokingly, if you can order a light chain assay once in a while, and if it's normal, it's okay. Maybe we need to be ordering that a little more frequently in someone who has protean symptoms to really identify the worst form of amyloid that this individual had, which was AL.
That's a great point. I don't think that we are being taught that in the schools, especially as a mid-level provider. Certainly, I did not have a lecture in amyloidosis. And certainly, nobody mentioned the Kaplan-Landa chain assay. So I think that's maybe something that we should include as we educate our peers into looking into this disease. It is not so hard to interpret. There's several resources that are out there, how to interpret these numbers, how to interpret the results, especially in the setting of chronic kidney disease. At the same time, we know that amyloidosis cannot be diagnosed, especially it cannot be diagnosed alone by blood work, and we need to pursue biopsies. And I think that's the second point that we have to make about organ biopsies. I know in the setting of cardiac amyloidosis, experienced centers, are often doing cardiac biopsies day in and day out in post-transplant or pre-transplant for diagnosis, but in maybe smaller regional centers, they are concerned about making the referral for a biopsy. When we look at the risk for which include, bleeding, infection, tamponade, certainly they're there, but they are, the data shows that they're less than 1% in experienced high volume centers, but AL patients have 100% risk of dying without a clear diagnosis in 6 months. So what are your thoughts on that?
Yeah, I would, as this case demonstrates, the diagnosis for AL amyloid is only made by a biopsy. Sometimes it's, not the kidney or the liver or the heart. It could be a fat pad, but even in a fat pad biopsy, if it's negative and your suspicion is high, you need to go on to an organ biopsy. It's pretty hard to perforate someone, which is the worst complication in the world, with cardiac amyloid. The walls are thicker, so I think we've overestimated the risks attributable to the procedure. Almost everyone we've ever biopsied at Columbia, for example, they've said, oh, that was all it was. It's literally a 10 or 15-minute procedure and they're off the table. And, light chain amyloid's a medical emergency. I mean, these are people who, God forbid they have advanced disease. They have median survivals, as the patient noted on the internet, of months. And so You can't dawdle here. This is something that has to be expedited in its evaluation and really move quickly.
Okay, so one more point was the question. Well, if I'm referring this patient to a hematology for a bone marrow biopsy, should I even pursue an organ biopsy? And as the patient mentioned, a bone marrow biopsy helps confirming, ruling in or ruling out multiple myeloma. On occasion, the tissue could be stained with Congo red, and on occasion, it may show some amyloidosis as well. But the real diagnosis has to come from a targeted, organ that is affected by the amyloid, or as Matt mentioned, a fat pad biopsy, which unfortunately is so low in the sensitivity that I certainly have a lot of patients who have come back with false negatives. What are your thoughts on that?
Well, I think the data supports the idea that, as you're indicating, the bone marrow biopsy is to evaluate the plasma cell dyscrasia to find out if there's a substrate for AL amyloid, excess plasma cells, God forbid, a huge burden that might qualify as multiple myeloma. Both of those diseases, amyloid and myeloma, can overlap. 1 in 7 patients with myeloma has amyloid, so they're not mutually exclusive. It's on the spectrum of plasma cell diseases. But a bone marrow biopsy will show amyloid in less than 10% of patients who actually have amyloid in an organ. And so you shouldn't conclude, because there's no amyloid in the bone marrow, that it's not present in the kidney, the heart, or some other organ. And you definitely need to go on to identify what organ is affected and to what extent it is affected. So I agree completely. Also about the fat pad, which is it's a useful test, but in the setting of a high pretest probability with a life-threatening disease, you should not be happy with a negative fat pad biopsy and end your diagnostic workup at that point in time.
Another question that I have, and this is maybe a tricky one. So I've always had the opportunity to work in big centers with amyloidosis experience. So oftentimes when we see a patient that, echo is consistent with AL or amyloidosis, and then we throw in the monoclonal gammopathy test and they're positive, we go straight for the biopsy. But I've seen other providers that they're hesitant in that point and they start pursuing imaging like cardiac MRIs, which I understand they are helpful, but in the setting of a medical emergency like AL, we are more prone to just sending for the biopsy. What is your regular practice, Matt?
I think it's quite similar to yours, but we obviously are a large transplant program. I have quite a bit of expertise, and so I moved to biopsy very quickly. As what was it Willie Sutton said, why he robbed banks, that's where the money is. And so if you see a dysfunctional heart on MRI or echo and you want to know what's really going on, pathology is important. I wouldn't want to be dictatorial, though, to providers. I mean, I think, to be honest, if you found a fat pad biopsy that was positive in the setting of a classic MRI findings, you know what the patient has, and they have cardiac amyloid, and people will institute treatment for AL amyloid in that particular circumstance. So we don't always require a biopsy of the affected organ to initiate therapy, but you shouldn't be shy about biopsying the affected organ.
Any other comments?
I just would emphasize, as this patient elucidated, early diagnosis here is the key to saving lives. And if you can find someone early in the course of this disease, you could make this a chronically manageable condition that is not fatal. And people can live long, healthy lives for decades when the disease is identified early. So that's the charge of all of us. Primary care providers, nurse practitioners, everybody, including subspecialists who focus on amyloid, is trying to facilitate an early diagnosis.
Agreed. Lou?
I think our discussion has centered around the idea that we're presented with a disorder which was originally thought to be rare. Typically, medical professionals call these disorders zebras. And now we have to start recognizing not only is it not a zebra, but we're going to hear its hoofbeats coming around much more often. And that when we look for this previously atypical disease, that just like when we talk about back pain, every primary care doctor knows most people have just some sort of lumbar strain. Nothing's going to happen terrible. But you must not overlook the one terrible component that is inexcusable, and that's cauda equina. And I think that by the information you've so generously provided my colleagues, we now have the picture. Cardiac amyloidosis is important. There's more than one flavor of cardiac amyloidosis. It is critical that if you're wise enough to start thinking of cardiac amyloidosis, don't miss the step of ruling out AL first. That's the cauda equina of cardiac amyloidosis. And I hope we've made that the case definitely and strongly.
Well put together there. And like we mentioned, the other thing that I think it's important is that you're not alone. There are centers of excellence around you, colleagues that are here for you. And that if you have the suspicion, it's just a phone call away where we can just get the patient in and, confirm the diagnosis and help the patient get to the treatment that they need. My name is Johanna, and I've had the opportunity to work with amyloidosis patients for over a decade, and I'm pleased to participate in this initiative that aims to improve recognition of amyloidosis patients in the primary care setting. So what is amyloidosis? Amyloidosis is an umbrella term that describes diseases caused by abnormal deposits of a protein called amyloid. Amyloid is a starchy substance caused by a normal protein that pathologically misfolds into a more linear shape denominated by beta platelet sheets. These misfolded proteins aggregate, forming insoluble fibrils that deposit into organs and causing tissue distortion and organ failure. In the case of the heart, these extracellular proteins have traveled through the bloodstream and have accumulated in the myocardium. There are many types of amyloidosis, but there are two that primarily affect the heart: amyloid light chain disease, or AL, and amyloid transthyretin, or ATTR. ATTR is further subclassified based on its etiology into hereditary, if it is caused by a genetic variant, or wild type, if it's not caused by a genetic component, but rather by an unknown pathologic process. We will discuss these types of cardiac amyloidosis using case studies to illustrate their clinical presentation, pathophysiology, and treatment strategies. Let's start with my case. This is Miss L.Y. She's a 47-year-old Caucasian woman with a history of atrial fibrillation and urinary incontinence managed by standard of care treatments. She developed dysphagia, hoarseness, macroglossia, who also noted dizzy spells. She was seen by her primary care provider, who noted the enlarged tongue, notable by the scalloping of the edges. This is caused by indentations from the constant pressure against the teeth. And as he was concerned, she was sent to the emergency room to see if she could be worked up for angioedema. So let's talk more about AL. Well, in the epidemiology part, we can say that there's about 4,000 cases diagnosed every year. It affects people of ages 40 to 80, although it is more common in the fourth and the fifth decade of life. However, we've seen patients that are as young as 20 years old that have been diagnosed with this disease. More importantly, we need to remember that without treatment, patients will die within 6 months of diagnosis. Therefore, we should consider it a medical emergency. Symptoms with AL may vary by patient. Initially, the symptoms can be minor or similar to those of many conditions or systemic diseases. Some symptoms can announce themselves quickly, whereas others may be subtle in nature. And for each patient, the clinical presentation will depend on which organs are affected by the amyloid deposits and the degree that the organ function is being impaired. But what's going on in amyloidosis per se? So AL in particular is a bone marrow disorder. You may recall that plasma cells make antibodies or immunoglobulins. Immunoglobulins are made up of heavy and light chains, as we can see in the picture there. They're paired together, perfectly together. However, when a plasma cell becomes malignant or clonal, it produces excess of light chains, so more blues than greens. Abnormal light chains become misfolded, clamp together into amyloid fibrils, and travel through the bloodstream to accumulate in tissues such as the heart, the kidneys, the liver, nerves, and amongst others. Patients may have different clinical presentations, but it usually affects several organs at the same time. So let's walk through an algorithm to diagnose amyloidosis. We have our clinical presentation, which includes EKG voltage discordance, Echocardiogram features including a large or a thick septum, which we call in the report intraventricular septum diameter of more than 1.2 millimeters. They can also say that the patient has biatrial enlargement, elevated NT-proBNP and troponin. Patients may also have neuropathic involvement, so they will have peripheral neuropathy and autonomic dysfunction features, nausea, vomiting, diarrhea, constipation, sometimes bouts of all of them together, albuminuria, and elevations on alkaline phosphatase. So if you have a patient that presents himself to the clinic and you have the suspicion of amyloidosis, where to start? Well, first and foremost, we need to screen for the presence of monoclonal light chain disease. And this is done by prescribing 3 different tests that we will describe in the next slide. So deciphering the light chains. The first test that we need to describe is these 3 tests. First, we'll start with a serum free light chain assay, which is the kappa lambda H assay. And they're used to detect no level clonal or abnormal light chain production. The normal range varies based on the renal function. So in the setting of a normal renal function, it will be between 0.26 and 1.65. If a normal renal function, you need to consider the interpretations based on the GFR. And I'm attaching an article that describes this at length. But for instance, if the GFR is 45, less than 60, or 45 to 59, the free light chain ratio will be 0.46 to 2.62. If it's less than that, again, the ratio will vary. So it is important to consider the renal dysfunction. However, if it is abnormal, we still have the concern for amyloidosis light chain. Although kappa lambda serum free light chain ratio, it's a great test for itself, it will not indicate amyloidosis alone. And for this reason, we also need to do serum and urine immunofixation studies. Both of these tests detect serum clonal or urine clonal immunoglobulin production. The normal read of this test, the normal results, will indicate that there is no MSCI present, which means there is no excess of a single antibody protein when compared to others. If abnormal, you need to consider a plasma cell dyscrasia, like monoclonal gammopathy of unknown significance, multiple myeloma, AL, or in 15% of the patients, that they may have both multiple myeloma and amyloidosis light chains. So if you either of these tests, including the free light chains, the serum or urine immunofixation studies that are abnormal, we now need to know that we need histologic proof of amyloidosis to confirm the presence or to rule it out or to read it in. So we go back to our algorithm, and once monoclonal gammopathy is identified, we need to pursue tissue biopsy. And I understand that this is a more invasive approach, but it really depends on the site of the biopsy. In the case of the heart, endomyocardial biopsy is still the gold standard with 100% sensitivity. Once the amyloid has been identified, however, tissue must be sent out for mass spectrometry. This is a special test that is carried out by the Mayo Clinic, and this will allow us to subtype the amyloid tissue into either AL or ATTR. Additionally, we need to consider referring the patient to hematology for further workup, including a bone marrow biopsy looking for multiple myeloma. Sometimes they also do fat pad biopsies looking for systemic disease. The problem with this approach, however, is that it's very low in sensitivity, and there's a lot of false negatives based on the technique. Many people ask, well, if we are doing a bone marrow biopsy, why do we need to do a heart or other organ biopsies? This is a great question, but the truth is that bone marrow biopsies are important to assess the number of plasma cells present in the bone marrow, but they're not rule out amyloidosis. On occasion, you can stain the same tissue with Congo green, and it will, on occasion, do show amyloidosis, but it's not always the case. Endomyocardial biopsies does come with risk, including bleeding, infection, tamponade, and death in less than 1% of the centers in experienced centers. This is a statement made by the Heart Failure Society of America, European Society of Cardiology, and Japanese Heart Failure Society. We know that this risk is minimized in high-volume centers with ample experience doing these procedures, particularly in patients who are also on anticoagulations. I understand that there's anxiety when ordering this test, but we also need to remember that AL patients will have a 100% risk of dying without a diagnosis, so we must be considering it. So let's go back to our case. We know how the patient presented and how the patient was sent to the emergency room. Well, the angioedema obviously was ruled out in the emergency room. The patient went back to the primary care provider as her disease spells had worsened. She was told to drink more fluids, which again worsened the incontinence. So she also was told to see a neurologist. The patient continued to struggle to no end. Unfortunately, she was due for a dental checkup. She mentioned her enlarged tongue to her dental hygienist to a routine clinic. The dentist, recognizing that this was abnormal, did send a biopsy from the tongue. That came back with positive for amyloid deposits. Unfortunately, in her case, this tissue was not sent for mass spectrometry. However, when the patient received the result in itself, she Googled amyloidosis and self-referred to a center of excellence. After workup, the patient underwent an endomyocardial biopsy that confirmed AL deposition in the heart. So what do we do when we diagnose AL amyloidosis? Well, treatments are targeted to plasma cells, and they are very similar to multiple myeloma treatments. These treatments are tailored by each patient, and they are focused on patient's organ and function, systems, symptoms, and preferences. In the Andromeda clinical trial in 2021, 388 patients received daratumumab in addition to a standard of care. The treatment arm achieved complete hematological response in a 53% comparing to 18%, and a significant difference in hazard ratio from organ deterioration, hematological response, and death when compared to the control group. In the United States, stem cell transplantation is often the preferred therapy as it provides long-term control of the underlying disease. However, the degree of cardiac involvement often determines if AL patients are eligible for this. The majority of AL patients, and in many countries outside of the US, only chemotherapy treatments are considered. What are we trying to achieve with the therapy? Well, primarily we are trying to achieve hematologic response, which is measured by the reduction of plasma cells in the blood. And there are multiple degrees of response, from partial response, very good partial response, and complete response. Additionally, we are trying to achieve organ response, which is measured by the improvement of organ function, measured by specific organ markers in each organ, and symptom reduction. So what are our case take-home points? Well, first and foremost, not all amyloidosis is one type. Particularly, not all amyloidosis is ATTR. AL is a medical emergency. We know that life expectancy is less than 6 months without treatment, and for this reason, we should and must roll it out as soon as possible. We are to remember diagnostic pitfalls. AL cannot be diagnosed or distinguished from ATTR via imaging, nor echo, PYP scan, or cardiac MRI, nor for blood work alone. The gold standard for diagnosis of all types of amyloidosis, including ATTR, AL, AA, or all types, is always target organ biopsy. This is particularly of importance for AL. Delays in evaluation may result in high index of mortality, so we must not delay the referral of this patient for this diagnostic workup. AL is a serious but treatable disease if diagnosed early enough to allow for successful therapies, including autonomous stem cell transplantation. In regards to Ms. LY, she was studied on treatment, but unfortunately her autonomic dysfunction and cardiac involvement debilitated her too much, and she died despite heroic OSHA's efforts to withstand therapy. So I'm asking you today to honor her by not missing AL ever again. Thank you.
Thank you, Johanna, for that excellent introduction and reminding us of the caveats as we approach this diagnosis. I'm going to speak to our audience from the perspective of a primary care clinician in relationship to ATTR cardiac amyloidosis. I'd like to begin with a quote because it clarifies for us some of where the confusion arises in reference to ATTR, and that is the disorder is a number of inherited and inflammatory disorders, and the other highlighted word that you would see is extracellular, because this process is primarily a disorder of deposition of proteins that compress the healthy tissues around them and result in tissue damage. A significant enough consideration that some have published, for instance, in this article from Journal of the American College of Cardiology, that amyloid cardiomyopathy should be suspected in any patient who has HFpEF. Let's look at some data about patients who underwent autopsy analysis, and we're looking at patients with HFpEF. The abbreviation WT-ATTR stands for wild type. As mentioned earlier, there are basically two major categories of amyloidosis. Wild type means just occurring spontaneously without any necessary hereditary component, and the other is hereditary or in reference to genetic disorders. So as we look at the age of death, you'll notice that in a control group, the patients had a very low incidence of amyloidosis, but if you go to people in their 80s and 90s in HFpEF, as many as in age 80s above 20%, and in 90s as many as 60-some% of people with HFpEF had evidence of amyloidosis. So this disorder, we're seeing HFpEF every day, and if you thought that 1 out of 6 or 7 of your HFpEF patients might actually have ATTR as the cause of that, you'd be on the right track. Let's make sure we're all using the same vocabulary. Transthyretin amyloidosis is the translation of ATTR. And you probably never heard of transthyretin, or if you're an older clinician like myself, transthyretin was previously called prealbumin, the name transthyretin being a simple transposition of the fact that the protein carries thyroid hormones and retinol. So transthyretin, a contraction of this is the protein that transports thyroxine and retinol. When I first became a student of ATTR, some of the first sentences talked about the, quote, protein misfolding disorder. And that sounded very sophisticated. Unfortunately, I didn't know what a protein misfolding disorder was, but you soon will. Because all of the disorders you see on the screen, of which you're likely very highly familiar with, but a couple of them not, each of those is a protein misfolding disorder. Now, you may have thought that protein misfolding disorders are something you never heard of, but actually, there are many protein misfolding disorders, a grouping of which you see on the screen. So we knew these under a different name, and we're going to learn specifically about ATTR. Remember the role of transthyretin. It is a protein that's built as a tetramer, meaning 4 components. 2 of the arms of the tetramer contain retinol binding protein, and 2 contain T4 binding sites. And you see here a typical transthyretin molecule. Well, let's look at the journey of the transthyretin molecule so you'll better understand both the normal and the pathologic metabolism. First of all, transthyretin is created in the liver. And that would make sense when you understand that in the old days, the treatment for transthyretin disorders was to do a liver transplant, so you do a different job of making transthyretin. The transthyretin travels to its target tissues and delivers T4 and retinol. You'll see that depicted below the target, where those retinol and thyroid donor sites are now pale because they've given up their necessary stuff. Well, normally, once the thyroid and retinol have been deposited, the TTR will fold and return to the liver for regeneration or donate amino acids to the amino acid pool. Unfortunately, the story is different if the transthyretin is unstable. That leads to misfolding. So as we watch the journey of the transthyretin molecule drop off its necessary contents to the target tissues and then head on a journey back to the liver, if it is unstable, it misfolds. The problem is our bodies do not have a pathway to effectively metabolize misfolded transthyretin. So it can't go to the liver for degradation and regeneration, and it can't donate to the amino acid pool. So what does it do? When it's not able to be metabolized in a functional fashion, it forms fibrils, none of which are able to be metabolized, that congregate into amyloid and lead to extracellular deposits where? To essentially everywhere. So you see depicted, it can end up in your eyes, your heart, the peripheral nervous system, autonomic, the GI tract. Any place that amyloid travels, it can cause pathologic damage by compression of tissues through its extracellular deposits. Now you might ask, well, what is it that makes the transthyretin unstable? There are a number of reasons why it becomes unstable. What we know is that once unstable, it becomes destabilized and the tetramer comes apart into its components. And those are the things that lead to misfolding. Now, why would it be unstable? Well, first, there can be genetic defects due to an amino acid substitution. If you have substituted genes with genetic abnormalities, you end up breaking your TTR into monomers that misfold. Why else? Well, just when tissues get old and gray, they will turn into misfolded proteins simply because older tissues sometimes lose their appropriate function. And sometimes simply because of overproduction of transthyretin. The picture I showed you of the travel between the folded up TTR in its way to the liver and to the amino acid pool assumed that there were a normal amount of these proteins. But if they're overproduced and there are not enough so-called chaperones to take them to their appropriate targets, they're left over to persist in the plasma and ultimately misfold and lead to amyloid. The two primary types of amyloidosis of the heart that you and I are going to focus on are going to be transthyretin, and you've already heard about AL. They all fall under the same large umbrella of being cardiac diseases, although you've learned that the AL amyloidosis is a disease of some urgency with ultimate fatality if not promptly addressed. And you and I will be talking about the hereditary with genetic defects or the wild type just occurring through typically most commonly aging that results in abnormal configurations of ATTR. Let's look at a typical patient. Now, you wouldn't have thought of this patient as typical for anything but his syndromes, probably prior to this communication. We're talking about a 72-year-old black male, and he's seeing his PCP for just a regular checkup. He just says, no, nothing's wrong except I'm getting older. He has New York Heart Association Class 2 symptoms, meaning he gets short of breath with moderate activity. His past medical history indicates carpal tunnel syndrome bilaterally and hypertension, and he's on appropriate medicines for a person with heart failure. He had an echocardiogram that showed some left ventricular hypertrophy with an intraventricular septum size of 1.3 centimeters and the diastolic dysfunction we would expect from HFpEF. Well, for instance, in Black Americans, as many as 1.5 million persons in the United States possess this most common hereditary ATTR abnormality, the valine 142 isoleucine genetic defect, which increases their risk of heart failure more than 2.5 times, and they do have an increased mortality associated with that. We know that the wild type is actually more common than the hereditary. It's associated with age and more commonly seen in men. And as many as 25% of people who are over 80 years old who have cardiac biopsies show evidence of cardiac wild type transthyretin amyloidosis. Similarly, supporting that concept is a Spanish study of 120 persons over the age of 60, where 13% were found to have wild type, that is non-hereditary, ATTR. There are some differences that can lead us to suspect one type of ATTR versus another. In hereditary ATTR, we see the disease occurring as early as age 20s. Males have it equally frequently with females, and the primary tissue targets are cardiac and peripheral nervous system, as opposed to with wild type cardiac and tenosynovial, for instance, people who might have carpal tunnel syndrome. So you'll see on our graph here that there are some things that help to distinguish hereditary from wild type, but in concert with what our earlier speaker said, we do want to be doing genetic analyses on persons who have any type of amyloidosis. Typically in the past, and this article was published in 2019, you'll see that the diagnostic delay interval was 2 or 3 years. And we're hoping to eliminate that so that when you see a person who has heart failure and they have one of the accompanying signs seen on this map, you'll think, well, maybe it's not just heart failure and autonomic neuropathy. Maybe it's not just heart failure and spinal stenosis. Maybe it's not just heart failure and carpal tunnel. Maybe it's ATTR. A common statement that can be heard in clinical medicine today would be, well, my patient has some symptoms and it suggests amyloidosis, but why should I bother to diagnose it? Because there's no effective treatment I've heard of. Well, that is an old perspective because fortunately, we do now have treatments that affect either the generation or the messaging or the activity of the abnormal accumulation of molecules that can forestall the consequences, in particular, of ATTR, and you see some of those agents listed for you there. These products do, in effect, provide protein stabilization and are able to make not only a clinically significant impact on symptoms, but have been even shown to reduce mortality. In summary, what we can say is that there's been meaningful advances in the diagnosis of ATTR. And now that we have therapies, and we have a good reason to search for them because they reduce mortality and improve quality of life. We want to consider, as is quoted in the journal from the American College of Cardiology, that what we once considered a zebra should now be considered on a much more regular basis.
Hi, my name's Matt Moore, and it's a pleasure to be here with you and present a case of cardiac amyloid in the setting of aortic stenosis, partners in crime. This is an 87-year-old gentleman who presents with worsening shortness of breath and a systolic murmur. He has multiple chronic conditions, including hypertension, diabetes, and chronic kidney disease, along with anemia, atrial fibrillation, and underlying coronary artery disease. He has additionally some orthopedic manifestations, including lumbar spinal stenosis and a previous bicep tendon rupture. His past surgical history is notable for a right hip and left shoulder replacement. On physical exam, he has a blood pressure of 126/76 with a heart rate of 90, and his BMI is 24. He has elevated jugular venous pressure at greater than 10, with normal being less than 8 centimeters of water. And he has a grade 3 out of 6 systolic murmur at his base of his heart with a soft second heart sound. He has an enlarged liver, hepatomegaly, with 2+ lower extremity edema. Laboratory testing shows that he has a creatinine of 1.2 with a hemoglobin of 11.8, mild anemia. His albumin is relatively normal, and he has a mild chronic kidney disease. He has elevated cardiac biomarkers with an elevated troponin and an NT-proBNP over 3,000. His EKG is shown, demonstrating sinus rhythm with APCs, and he has notably Q waves in his inferior leads and poor precordial R wave progression. So he does undergo an echocardiogram, which is shown here in still images. He has a preserved ejection fraction, and you can see his septal wall thickness is increased at 18 millimeters. He has a altered geometry with a high relative wall thickness, so a small ventricular chamber but increased wall thickness. It's got a low mitral S wave, so his tissue Doppler velocities are decreased, I should say, at the annulus. And you can see on speckle strain shown here, he has an apical sparing pattern with a preserved strain shown in the bullseye pattern here in red at the apex of his heart. A Doppler shown here demonstrates a peak aortic velocity across his LVOT of about 2.8 meters per second, and this calculates out to an aortic valve area of 0.6 centimeters squared, indicating a significant aortic stenosis.
Matt, I was wondering about that echo that you showed, because some of my colleagues have told me that they have to actually order the strain view, that it doesn't come automatically. Is that something we need to advise clinicians to include as they start their search for further diagnostic clues?
Yeah, it's a great point. I think that's an important message. It's variable in different laboratories, but in a patient who you may suspect amyloid, if your lab doesn't routinely do a speckle strain, I think that's an important thing to order as an augmentative diagnostic clue for the diagnosis. Apical sparing is seen in patients with chronic kidney disease and other disorders. It's not specific for amyloid, but certainly raises the possibility. So this particular individual, after long discussions with him, did undergo a TAVR, but post-TAVR, he underwent a technetium pyrophosphate scan with both planar and SPECT imaging. You can see here that there's diffuse myocardial uptake seen on planar imaging, and on SPECT imaging shown here, you can see that there's diffuse uptake that's localized in the wall of the myocardium, both on a cross-sectional short axis and longitudinal views. You can't interpret a PYP scan in the absence of an assessment for AL amyloid or monoclonal proteins, which he underwent, and he had a mildly increased kappa with a normal lambda and a slight normal ratio. This is typical in patients who have chronic renal insufficiency, as kappa requires normal renal function and clearance, and so we see often a slightly higher kappa in an older adult with chronic kidney disease. Immunofixation of the serum and urine showed no evidence of monoclonal proteins. And so a positive PYP scan with normal monoclonal protein assessment establishes the diagnosis of transthyretin and cardiac amyloidosis. He underwent genetic testing, which did not show any variants, and so he has wild-type disease. And he was treated with TTR stabilizer tafamidis. This phenomenon of the coexistence of TTR cardiac amyloid in the setting of significant aortic stenosis is not a rare phenomenon, as highlighted by many of these studies here, which show various prevalences of cardiac amyloid individuals who have severe aortic stenosis, and on average, about 10 to 15% of individuals have been reported to have concomitant cardiac amyloid in the setting of significant aortic valve disease. Yeah, I agree completely. That emphasizes the importance. So again, we advocate to rule out AL amyloid first because it's a more serious and life-threatening disease. And so in a patient with severe aortic stenosis, so you have phenotypic suggestions of cardiac amyloid monoclonal proteins first. If they're negative, then a pyrophosphate scan, always with SPECT imaging to confirm that the uptake is in the myocardium that's seen on planar imaging, it's not in the blood pool, and then genetic testing to determine if the patient has variant or wild-type disease. So I think the key points from this case are that the concomitant coexistence of amyloid with aortic stenosis is not rare. 1 in 7 to 1 in 8 individuals have the coexistence of these two phenomena, and so in individuals who have very thick-walled hearts, non-dilated ventricles, extracardiac clues, including low voltage, elevated cardiac biomarkers, or a host of orthopedic manifestations, amyloid should rise to the top of your differential along with the aortic stenosis. It is important to realize that when you do identify amyloid in the concomitant coexistence with aortic stenosis, mainly the aortic stenosis is often addressed by a TAVR in these individuals. Amyloid hearts don't really like to undergo surgical intervention with cardioplegia. So TAVR is really the preferred therapeutic strategy to address the aortic valve disease.
So challenges in patient diagnosis, referral, and support. Well, let's start with the first challenge, which was identified by the poll question as a diagnosis. So one of the challenges is that symptoms for amyloidosis are non-specific and could mimic other conditions, right? And this has created a trend of non-screening versus over-screening patients over the disease. Fortunately, Nativi Nicolaou and colleagues developed a tool to provide guidance in regards to who should be screened for cardiac amyloidosis. And it starts with patients with heart failure with thick septum. So to review, that's the inventricular septum diameter of 1.2 millimeters or more, regardless of their EF or ejection fraction. If you have a patient with a thick septum and has another cardiac or non-cardiac symptom, including atrial fibrillation, bradyarrhythmias and pacemakers, conduction abnormalities, or whether it's back pain secondary to spinal stenosis, shoulder and knee and hip pain, neuropathy, muscle weakness, or autonomic dysfunctions, you should pursue the diagnosis of cardiac amyloidosis. Number 2, perhaps, is the lack of urgency to complete the diagnostic workup. When you see this echo, there's multiple etiologies that could be described in there. You think, is it hypertension? Is it AL? Is it ATTR? Or is it me that I'm just seeing things that should not be there? The truth is, amyloidosis is not a mutually exclusive diagnosis. Then it could carry so patients could carry a diagnosis of hypertension, but also have the genetic mutation and subsequently develop the ATTR disease. So to this, we should also consider amyloidosis in all cases unless ruled out. When in doubt, you should always pursue the workup. Remember that patients are allowed to have as many diagnoses as they like, so do not be fooled by other diagnoses within the same patient. Number 3 is the multi-step diagnostic algorithm. We saw that it was not an easy thing to follow with many steps and intricacies that may delay an actual diagnosis. So to this, I'm saying you can call a friend. You can identify the patient and just refer the patient to a center of excellence. I'm listing here in this several websites that can provide guidance on where to send the patient in every state. So you don't have to make the diagnosis alone. There's definitely people that can help you get to a right diagnosis. But how about genetic testing? As described before, this is a part of the workup that has to be performed in order to subtype ATTR as either hereditary or wild type. One thing that we have to remember is that a lack of family history does not rule out hereditary disease, as patients may be considered patient zero in each family. To this day, our genetic testing is free or affordable through industry partners. So financial concerns for the testing itself, they should not stop you. However, there are multiple financial, emotional, and psychological repercussions to patients when they know that they have a familial or hereditary disease. So we need to consider referring the patient to a genetic counselor prior to sending the lab sample. Pre-testing discussions should include basic pathophysiology of the disease, the GINA Act, or the Genetic Information Non-Discriminatory Act, that describes the repercussions on life insurance policies and health insurances in general. If positive, they can also describe who should be tested in the family, and they should provide guidance in regards to how to deal with reproductive decisions, survival guilt, and how to share the information with other family members. If you don't have a genetic counselor as part of your team, there are other resources that I'm listed in this slide, including the National Society of Genetic Counselors, that will provide some guidance on where you can send the patient. Another one is the cost of therapy. So we'll start with AL. Okay, so as we know, chemo is not cheap, but fortunately, most insurance companies do cover it because of the urgency of the care. However, patients may be hit with infusion and clinic costs or hospitalizations that are not included in their coverage. Also, I learned that daratumumab is actually based on patient's weight. So this cost that I'm listing here is based on a patient that weighs about 120 pounds. Patients that are heavier will get higher doses, and for this reason, that will be charged more. Lastly, stem cell transplantation, very pricey. And not just the procedure, but also the hospitalization and the follow-up within the first 3 months, which is quite expensive there. But how about ATTR? Well, as it was explained earlier today, over the last 5 years, we have developed disease-modifying therapies that have changed the trajectory of ATTR patients, but it has not come cheap. In fact, a cost-effective analysis looking at survival, quality of life, and admission rates using the ATTRACT trial data determined that tafamidis added a total of 1.29 quality-adjusted life years at a cost of $1.1 million, meaning for every 1 year, one good year added to the quality of life of this patient, the healthcare system is paying over $800,000, making tafamidis the most expensive cardiovascular drug on the market in the US. This study also reported that in order to make it cost-effective, we will have to cut the price from $225K to $16K per year, which is about 92% of the price, which is unlikely to happen. But this is just one study, right? Why should we care? Well, because these are the type of studies that insurance companies and policymakers look at determining insurance coverage and healthcare policy reforms. So if we really think about it, ATTR therapy is quite inequitable, with some patients being able to afford concurrent double therapy, like tafamidis and vutrisiran, while others are able to afford none. To make matters worse, since the study was done, Vyndamax's price has increased to $265,000 a year. Fortunately, there are other options which we'll discuss later. But first, we should discuss about the hidden financial cost of therapy or amyloidosis. But first, multi-organ involvement means multiple clinic visits, labs, diagnostics, tests, which includes gas, parking, and parking costs. Loss of wages, which means times off due to the illness and treatment, reduced hours, demotions, FMLA use, not just for the patient, but perhaps the companion or the person, the caretaker that is helping out. Medical insurance policy changes, high premiums, co-pays, deductibles, and the policies of Medicare and Medicaid. Life insurance policies, which may be denied in the setting of hereditary disease, and also multimorbidity. As we know, amyloidosis is not the only disease that our patients may have, especially in the aging population. So what can we do about it? Well, there are resources available that are helping many patients receive therapy at little to no out-of-pocket cost. Thanks to our industry partners, nonprofit organizations, and even private funding, patients are being able to obtain these treatments, as well as they're being able to participate in clinical trials. However, patients must meet financial criteria to be able to obtain the services, and some patients are just not able to qualify. Patients need assistance navigating the healthcare system. And for this reason, social workers, specialty pharmacists, advanced practice providers, or nurses have become a vital part of amyloidosis programs, not just to obtain access to treatment, but to clinically manage the patients and prevent hospitalizations and further healthcare costs. All right, so in conclusion, amyloidosis is a multi-system disease that presents multiple challenges to both patients and providers alike. It really takes a village to provide a strategic, coordinated care to this population. As we diagnose patients earlier in life and their chances of survival improve, more resources will be needed to support these patients in the long term. Amyloidosis centers of excellence may provide the infrastructure needed to provide the care that these patients need. But this can only be achieved if referral partners, meaning you, screen patients on a regular basis and either make the correct diagnosis or send the patients their way in a timely manner. Not long ago, I remember when we thought of amyloidosis as a death sentence. We have come a long way developing novel, effective treatments to make it a rather chronic disease. However, this is only possible if we diagnose and provide access to the treatment as soon as possible. Remember that if you're not looking for it, you won't find it. Thank you.